Welcome to the program. I'm your host, Neal Howard. Thank you for joining us here. Today, I've got a guest in studio, Dr. Ahmed Tawakol. He's co-director at Cardiac MR and PET CT program, and he's joining us today to talk about his work in the field of cardiology there at Mass General, his research, and some of the topics that he presented recently at the American Heart Association's Scientific Sessions 2017. Welcome to the program, Dr. Ahmed Tawakol. How are you?
Doing well. Thanks for inviting me.
Let's give our listeners a bit of background about yourself. You are a cardiologist. Describe some of your training and background in the field, and a little bit about your role there at Massachusetts General.
Sure. I went to Stanford Medical School, after which I was at the Brigham and Women's Hospital in Boston for internship, residency, and cardiology fellowship, and then did advanced imaging training in nuclear cardiology at the Massachusetts General Hospital. I've been here since my training years. Currently co-director of the Cardiac MR, PET, and CT program. Also a practicing cardiologist.
Mm-hmm. Now, recently, as I mentioned, you participated in the American Heart Association's Scientific Sessions 2017. What are the scientific sessions? Do they cover a number of topics, or is it cardiology related? What is your knowledge of that event there?
The American Heart Association Scientific Sessions is one of our largest scientific sessions in the field of cardiology. It's an exciting meeting. People present topics in cardiology that are very wide, from treatment and diagnosis of cardiac diseases to really trying to understand the basic biology to far-reaching aspects touching on cardiometabolic disease as well as socioeconomic factors leading to cardiovascular diseases. It's very broad. For the clinicians and scientists attending, it's an opportunity to really leverage that breadth and kind of expand on the topics that one would otherwise typically be exposed to, and kind of try to grow through greater exposure to exciting new science.
Well, let's talk about maybe one of those scientific breakthroughs or topics that you personally presented at this year's session.
So one of the aspects that my group has been particularly interested in better understanding is the link between socioeconomic stress and disease. We've known for centuries, literally, that there is an increased incidence of disease in individuals who have protracted stress. But only recently have we begun to understand how that works. For example, for a long time, we were biased to believe that the link between stress and disease was really carried by either behaviors or increased blood pressure, but that it wasn't necessarily an independent risk. But over the last decade and a half or so, large studies with up to 25,000 patients included, for example, have shown that the link between stress and disease is really independent. About 5 to 7 years ago, animal studies started to suggest that the stressed brain might trigger an inflammatory response where the bone marrow produces a lot of extra cells that contribute to inflammation. So we wanted to see if a similar phenomenon were occurring in humans where stress leads to activity in the brain that then generates an inflammatory response by prompting the bone marrow to produce more immune cells. We recently published a paper where we observed just that in 293 individuals who had brain imaging and who were then followed for up to 5 years to look for the development of cardiovascular conditions such as myocardial infarctions and stroke. We saw that the amount of metabolic activity in the amygdala, the portion of the brain that is highly responsive to stress, was independently predictive of their risk of subsequent stroke and heart attacks, and that it was a relatively strong signal. The individuals who had strokes and heart attacks soon after imaging had the highest amygdalar activity. Those who had latter events had intermediate activity, and those who never developed an event had the lowest activity. We also found that the activity in the brain predicted the activity in the bone marrow as well as inflammation in the artery wall, and were able to construct a model that was very similar to what was seen in animals, where stress begets highly active amygdalae, which prompt increased bone marrow turnover of immune cells, which prompts more arterial inflammation, which then leads to cardiovascular disease events. The interest there is that kind of system gives us now an opportunity to try to interrupt it. And once you characterize a system, there's then that chance that you can devise treatments to try to modulate that system in hopes of reducing stress-related cardiovascular disease events.
Basically, dealing with it after the stressors have already done the damage. How much effort goes into making sure that those stressors don't reactivate the bone marrow in the future while undergoing whatever treatment that you're administering?
That's a really good question. So what's interesting about the brain in response to stress is that imagine stress as a weight and the amygdala as a muscle. The more exposure to stress the amygdala has, the larger it becomes, the more active it becomes. So stress begets more stress sensitivity. And so the issue is not so much to get rid of the stress. I mean, that's a very hard task for physicians to be able to modulate, and actually a very hard task for anybody to try to manage. The more reasonable ask is to try to change the response to stress. And there are ways to do that. You can have a reduced sensitivity to stress by reducing the size and activity of the amygdala. And that could be one of the ways to modulate the downstream responses. One could also devise drug therapies that could interrupt some of the downstream stages. For example, the production of inflammation is something that we could target with specific anti-inflammatory measures.
Have you noticed or touched upon any methods not drug-related that reduce the size of the amygdala?
So we are starting to look at that, but other groups have demonstrated that some meditative aspects could reduce the size and activity of the amygdala. And so that's one interesting approach. For example, mindfulness meditation has been shown to shrink the volume of the amygdala. Others have noted that exercise can very nicely reduce some of those downstream stress responses and also have other very fascinating impacts on the brain as well. So yes, there are some non-pharmacologic aspects that might indeed be very, very interesting.
Are those solely based on the progress of the stress and the size of the amygdala?
The mindfulness meditation and exercise can affect the size and activity, and the downstream impacts are things that still require a little more study. Though I would add that there was a very interesting study published about a year ago, wherein they took individuals with recent heart attacks or heart procedures and randomized them to either standard cardiac rehab with exercise or rehab with exercise and the addition of a stress reduction. And what they found is the individuals who had the more complete cardiac rehab with stress reduction experienced a 50% relative risk reduction in subsequent heart attacks and strokes or cardiovascular disease events over the next 5 years. That's a relatively small study and certainly requires replication in a much larger cohort, but kind of gives us some insight into the possibility that a stress reduction approach might have benefits in terms of cardiovascular diseases. Of course, the mechanism of that benefit is something that also requires some study.
Now, this is a question that I should have asked at the outset, but in wrapping up, I want to go ahead and touch on it. When it comes to imaging to determine some of the condition and some of the risks, what is the best type of imaging to make that determination, to make a proper diagnosis?
So one requires relatively advanced imaging to make these measures. Probably the most complete approach is to use PET MR imaging. So combined positron emission tomography and MR imaging, where the MR can give us information on the volume and the connectivity of the amygdala and associated brain structures. And the PET gives us information on the metabolic activity of the amygdala, and that's the contemporary approach that we're using to studying this. This is not a clinically used approach, rather complex and available to a small number of centers across the world. But in terms of driving the science, it's a very, very useful tool and an exciting one.
Where can we learn more online about some of this imaging and some more about some of these developments that were presented in this year's sessions?
Absolutely. A lot of the exciting presentations are available at the American Heart Association website.
Well, thanks for taking the time and talking with us today. Dr. Tawakol, I'm hoping you'll come back and talk with us in the future.
It's my pleasure.
You've been listening to Health Professional Radio. I'm your host, Neal Howard. Transcripts and audio of the program are available at healthprofessionalradio.com.au and also at hpr.fm. Subscribe to the podcast on iTunes, listen in, and download at SoundCloud. And be sure and visit our affiliates page when you visit our platform at hpr.fm.